Well, I guess one way to think about ourselves as human beings is that we consist of essentially two components. There's the brain and there's the body. Now, it's the brain that does all the cognitive and neurological processing. So the brain is receiving sensory inputs from the body, from the eyes, the ears, the nose, the tactility, the proprioception. And all this sensory information is going into the brain. And in a most amazing way, which isn't really understood, in fact isn't really understood at all, the brain uses this massive information and neurological processing to generate consciousness. The brain also processes all this information so that we can be interactive with our surroundings in a meaningful way, that we can respond appropriately to particular situations. So, for example, one way the brain will respond to a particular set of sensory inputs is to initiate a motor response, a movement response, to facilitate a coordinated set of movements. So if I perceive a threat in the environment, I'll behave appropriately to move away from that threat. We can take action which is appropriate because the brain is able to process this sensory information. Now, what this clearly means as a consequence is that the brain has to be able to communicate with the body. There needs to be communication systems, both sensory information going into the brain, this great central processing unit, and there needs to be information leaving, coming out from the brain to initiate and coordinate control of the body's physiology and the behavioural responses which are facilitated through the medium of the body. Now, despite all of the complexity and massive information involved, the body only uses two anatomical systems to facilitate this ongoing exchange of afferent information going into the brain and efferent information leaving the brain. Now, the first anatomical system is well known. It's the spinal cord. So the spinal cord is continuous with the bottom part of the brain stem, with the medulla oblongata, and it goes down the vertebral canal, normally terminating about the level of the second lumbar vertebrae. Now, leaving the spinal cord, there are 31 pairs of spinal nerves, which the spinal cord uses to communicate with the rest of the body. Actually, in a sense, the spinal cord is a continuation of the brain because it's part of the nervous system. So what we could say is that the brain communicates with the body via 31 pairs of spinal nerves. So that's the first system of this brain-body communication system, via the 62 spinal nerves, which are of course arranged in these 31 pairs. Now, the cranial nerves communicate directly between the brain and the body. They arise from the brain itself, within the cranial cavity. And this means to get out, they have to pass through the bones of the cranium to communicate with areas of the body. Now, a foramen is a window. So the cranial nerves have to pass through foramina of the cranium to get in and out. So I've said they arise from the brain. Well, actually, cranial nerves 1, 2 and 3 start peripherally. They arise peripherally. So 1 is the olfactory nerve that arises from the nose. 2 is the optic nerve from the eyes. And 8 is the vestibulocochlear nerve that arises from the inner ear, from the cochlea and from the vestibular apparatus of balance. These three nerves, or these three pairs of nerves we should say, are entirely sensory, carrying afferent impulses into the brain. All of the other nerve pairs are motor or carry both motor and sensory fibres. Or to be a bit more precise, nerve pairs 3, 4, 6, 11 and 12 are entirely motor, leaving 5, 7, 9 and 10 which are mixed motor and sensory. Now, the cranial nerves are not part of the brain and the spinal cord. Therefore, they are part of the peripheral nervous system. And the motor components are considered to be lower motor neurons, the upper motor neurons being within the brain itself. And each pair of nerves has a name and a number in Roman numerals. Now, you do get some people who put the numbers of cranial nerves in conventional numerals, but the correct way to do it is in Roman numerals. It saves confusion. Once you've learned how to count in Roman numerals, of course, which I think most of you can do. And they are counted anteriorly to posteriorly. So we start counting at the front and move towards the back of the brain. 1, 2, 3, 4, 5, as we move posteriorly, as we move backwards. Now, the cell bodies of the sensory axons are located in ganglion outside the brain. Now, a ganglia is a collection of nerve cell bodies in the peripheral nervous system. So the cell bodies of sensory axons taking information in for the sensory cranial nerves are located in ganglion outside the brain. And we'll see examples of this, of course, when we look at the olfactory, optic and the vestibulocochlear nerves. The cell bodies of the motor axonal fibres going from the brain out to the peripheral nervous system are located within nuclei in the brain. So a ganglion is a collection of nerve cell bodies in the peripheral nervous system, and a nucleus is a collection of nerve cell bodies within the central nervous system. So there'd be one nucleus, several nuclei. Now, the first pair of cranial nerves, nerve 1, are the olfactory nerves. Now, olfaction is to do with smell, the sense of smell. And these are purely sensory. They only contain sensory fibres. And these sensory nerve endings are located in the olfactory epithelium, in the superior surface of the nasal cavities. And the cell bodies of the first neurons in the olfactory pathway are also located within this olfactory epithelium. Now, these olfactory neurons are just that. They are neurons. They are nerve cells. And for years we were taught that nerve cells didn't divide. There was not ongoing mitosis in nerve cells. But in fact, we now know this is not true. Now, there's essentially no mitosis in the cerebral cortex. But in the deeper areas of the cerebrum and other parts of the brain, there is a limited amount of ongoing mitosis throughout life. And in these neurons located in the olfactory epithelium, there is ongoing mitosis. They keep dividing throughout life. And recently, neuroscientists and neurosurgeons have realised this and have actually harvested some of an individual's olfactory neurons, transplanted them into other parts of the body to try and facilitate neuro repair. And it's hoped that with further development in the future, this potential for ongoing mitosis could be utilised to heal central nervous system injuries, such as spinal cord lesions, which tragically result in paralysis. But that's a bit of an aside. Now, each olfactory sensory neuron, these are actually called bipolar neurons. So they have a short single dendrite, which is the actual peripheral sensory receptor. And this short single dendrite takes the new nerve impulse into this peripheral olfactory neuron cell body, and the impulse then passes out of a single unmyelinated axon. So this means the actual transduction of chemicals in the air in the nasal cavity into neuronal nerve impulses is facilitated in the dendrites of these initial olfactory neurons located in the olfactory epithelium. And what transduction means is that an external impulse is converted into a nerve stimulus. And we see this is the same with all sensory neurons. So, for example, light waves in the eye are converted into nerve impulses by this process of transduction. And that's essentially what smell is. It's often said that smell is taste in small amounts. So these olfactory peripheral sensory receptors are sensitive to various chemicals in the air, in the nasal cavities, and they code this information into nerve impulses. Now, once these axons leave the initial olfactory neurons, bundles of axons pass through about 20 forama, these small windows. And these 20 forama are located on each side of the skull, and they form what is called the Cribriform Plate. So the Cribriform Plate is 20 small forama, all located in a small area, and we have bundles of the axons carrying the olfactory information through into the brain. So each olfactory nerve has about 20 bundles of olfactory axons carrying information into the cranial cavity. Now, this Cribriform Plate is a bit of a, well, it's somewhat of a weakness in the defences of the central nervous system, because viruses and bacteria don't have far to travel through the forama of the Cribriform Plate to get from the nasal cavity into the cranial cavity. And this is one of the mechanisms whereby meningitis, for example, can get in to the cranial cavity. The meninges being the protective layers that surround the brain, and viral or bacterial infections can get from the nasal cavity through these small forama in the Cribriform Plate into the meninges. And of course, if the meninges are infected, that is called meningitis. Now, when these axons from the primary olfactory neurons pass through the forama, they go into paired areas of grey matter called olfactory bulbs. And these olfactory bulbs sit just above the Cribriform plates. They're essentially very small outgrowths of the brain. And here they synapse with sensory dendrites. That takes the information onto a second cell body of the next neuron in the olfactory tract. And it's the axons of these second olfactory neurons that then travel posteriorly as the olfactory cranial nerves to the olfactory areas. Now, the olfactory areas, there's one in each temporal lobe in the brain. So all of this information is taken into the olfactory areas in the temporal lobe in the brain, in each temporal lobe. And these nerves don't cross over. So the nerves from the right side go to the right olfactory areas in the right temporal lobe, and the impulses from the left side, from the left olfactory nerve, pass into the left temporal lobe, into the left primary olfactory area. So there is no decussation. Decussation means crossing over. These fibres don't decussate, they don't cross over. So you probably know it's the right-hand side of the brain that controls the left-hand side of the body, and the left-hand side of the brain that controls the right-hand side of the body. To facilitate that, there has to be a crossover of neurons. This crossover is called decussation. But we see in this olfactory nerve tract, there is no crossing over. There's no decussation. Now, when these electrical nerve impulses carried in the olfactory nerve arrive in the primary olfactory area in the temporal lobe, the primary olfactory areas generate a sensation of smell that we then experience as smell. So in some way that's not understood, these electrical nerve impulses are connected into this aspect of consciousness that we call smell. Now, it's interesting to know that before people have epileptic episodes, quite often they're aware of a taste or a smell. This is called an aura, and an aura can often present before a generalised tonic-clonic seizure. And this is due to abnormal epileptic type activity within the temporal lobe generating this abnormal sensation, which is in essence a hallucination. It's a perception without an external stimulus. How the sense of smell is generated and how that is transposed into our conscious experience is not understood. The modality via which the brain generates consciousness is not understood. Now, the second pair of cranial nerves are the optic nerves, and these only carry sensory fibres. And the optic nerves are taking visual information from the retinas of the eyes back into the brain, where it's processed and turned into vision. Now, Having said that the cranial nerves are peripheral nerves, that was a bit of an overgeneralization really, because the optic nerve is an exception. It's actually considered part of the central nervous system. So the myelin sheath on the optic nerve, that fatty covering on the nerve fibres, in the optic nerve, this myelin sheath is actually produced by oligodendrocytes rather than Schwann cells. And this distinction is important because it's the oligodendrocytes that produce the myelin in the central nervous system, whereas the Schwann cells that produce the myelin in the peripheral nervous system. So this would argue in favour of the optic nerve being a part of the central nervous system. And also the optic nerve is encased in the meningeal layer. And this is important because patients with multiple sclerosis can develop a retrobulbar neuritis, pain behind the eye causing visual disturbance because of inflammation affecting the myelin sheath surrounding the optic nerve. And we know that MS, multiple sclerosis, only affects the oligodendrocytes of the central nervous system. But anyway, we'll leave the anatomist to argue about that one. Now, you've probably heard of the rods and cones, the light-sensitive cells in the retina. The rods are sensitive to low light levels and give rise to monochromatic black and white type vision that we use at night when we can only see in shades of grey. Whereas the cones respond to bright light stimuli and they generate colour vision. Now, these rods and cone cells are on the base of the retina and they communicate up, going in towards the centre of the eyeball with bipolar cells. So a dendrite from the bipolar cells will communicate with the rods and cones, and this will carry the now electrical nerve impulse from the dendrite of the bipolar cell through the bipolar cell body to the axon of the bipolar cell, and then this synapses again with a ganglion cell. And it's the axons from the ganglion cells that form the optic nerves which leave each eye. Now, it's often argued that it's illogical to have these bipolar cells and ganglion nerve fibres in front of the rods and cones, because after all, the light has to pass through this layer of bipolar cells and ganglion cells to reach the light-sensitive rods and cones of the retina. All I can say that visual resolution is quite incredible. My eyes give rise to much more detailed visions than my cameras or video cameras do, so it seems to work fairly well. Anyway, there's an optic nerve leaving each eye, and these optic nerves pass through the optic foramen of the back of the orbit. So the optic foramen is essentially a window or a hole in the back of the orbit that allows the optic nerve to leave the eyeball, to leave the orbital cavity, and to go back into the cranial cavity. Now, these two nerves go back a little way, then they cross over at an area called the optic chiasm. Chiasm is crossover point. So they form like a cross, and this crossover, this chiasma, is near the pituitary gland. So pituitary tumours can cause visual disturbance because they compress on the optic chiasma. Now, most pituitary tumours are adenomas, and they can grow quite big, so-called macroadenomas. And this can cause pressure on the optic chiasma, resulting in visual disturbance. And this presents usually slowly and progressively, and it can decrease central acuity, the central visual fields lose their resolution, or it can present as a loss in peripheral visual fields. Anyway, after the crossover, after the chiasma, the two optic nerves pass further back into the thalamus. And the thalamus is the great relay centre of the brain. There's a thalamic nuclei on the right and on the left side of the brain. And here the optic neurons synapse, and the axons then travel posteriorly to the primary visual fields. So the ganglion cells that picked up the nerve impulses from the bipolar cells terminate in the thalamus, synapsing with other neurons, and the axons of these other neurons travel posteriorly back into the primary visual fields. And the primary visual fields are located at the back of the brain in the occipital lobes, at the very back of the brain. Now, the way that the fibres cross over at the chiasma is interesting. Fibres from the lateral retina stay on the same side, but fibres from the medial retina cross over. And what this means, if you fix your eyes looking straight forward, so you're not moving your eyes are just looking straight forward, and that means that your right visual field is seen with the left occipital lobe, and the left visual field is seen with the right side, the right occipital lobe of the brain. And actually, after the chiasma, a few fibres go to the midbrain and synapse with motor neurons of the third nerve, which we'll think about next, the Oculomotor Nerve. But the vast majority are going back to the occipital lobes. And in the occipital lobes, these electrical nerve impulses, which were generated by transduction of light into electrical nerve impulses in the retina, are once again interpreted as light and give rise to the sensation of vision that we experience. So our visual perception is actually generated in the occipital lobes at the back of the brain and experienced as part of consciousness. Now, cranial nerve 3, the third cranial nerve, is the oculomotor nerve. And the third nerve is entirely motor. It is carrying impulses from the brain out to the periphery, in this case to the eye. And it's actually the first nerve that arises from nuclei in the brain stem, actually in the midbrain. And oculo, of course, means to do with the eye, and motor means to do with movement. So this is all about controlling movements of the eye. And this includes muscles on the outside of the eye, the so-called extrinsic eye muscles. And it also controls some of the muscle innervation inside the eyeball, the so-called intraocular muscles. Now, the oculomotor nerves are the lower motor neurons of the oculomotor system, and they arise from nuclei in the right and the left side of the oculomotor nuclei in the brainstem. So there's oculomotor nuclei on the right and on the left-hand side of the brainstem. Now, the right and the left oculomotor nerves run forward from the midbrain where they originate. They are running anteriorly. And as the nerve nears the eye, it divides into two branches, the top and the bottom branch, the inferior and the superior branches. And both of these branches enter the orbit by passing through the superior orbital fissure. And this is just a gap in the orbital bones, allowing a communication between the cranial cavity and the orbit, which is housing the eye. Now, the superior branch innervates some of the external eye muscles, the extraocular muscles. And these are the muscles that facilitate movement of the eyeballs, so we can look in a particular direction. The specific muscles which are innervated by the superior branch of the oculomotor nerve are the superior rectus eye muscles, and this superior branch also innervates the muscles of the upper eyelid as well. And it's axons from the inferior branch, also of the oculomotor nerve, that supply other external extraocular muscles. Specifically, the inferior branch supplies the medial and inferior rectus muscles and the inferior oblique muscle. The rectus muscles are the straight muscles which control movement of the eyeball. Rectus means straight. So when there's coordinated contraction of these, both of the eyes can look at exactly the same point in our visual fields. So we can look exactly at the object we want to gain information about. Now, branching off the inferior branch, there's actually another smaller nerve branch which passes into the eyeball and so becomes intraocular. It goes into the eyeball. And this goes on to provide parasympathetic innervation to the intraocular eye muscles. And these muscles are the ciliary muscles, which control the shape of the lens. And of course, controlling the shape of the lens is vital for focusing. And specifically, these fibres facilitate thickening of the lens for focusing on near objects. And other branches control the circular muscles of the iris, the sphincter pupillae muscles, causing the pupil to constrict, getting smaller And this is an adaptation to bright light, preventing too much light entering the eye and helping to give a sharper focus. So this parasympathetic stimulation is causing constriction of the pupil, making the pupil smaller. Now, having said that the oculomotor nerve is entirely motor, that's, as is often the case in neurology, somewhat of a generalisation. It is true, but there are in fact some sensory nerves that start to leave the orbit in the oculomotor nerve. And these carry proprioceptive information about the position of the eyes from the state of contraction or relaxation and the movement of the extrinsic eye muscles. So they start off their journey back to the brain in the oculomotor nerve, but these sensory fibres leave the oculomotor nerve and join the ophthalmic branch of the trigeminal nerve. So they don't go back to the brain with the oculomotor nerve fibres. So it is fairly true to say that the oculomotor nerve is entirely motor. Now, the reason that the oculomotor nerve is famous in healthcare, of course, is because we're testing this every time we examine the patient's pupils. So when you shine a light in your patient's eye, the pupil will constrict. And this is because of parasympathetic stimulation from the inferior branch of the oculomotor nerve. Now, we've said that the oculomotor nerves, the right and the left, arise from the midbrain. And as we've said, this means that the nerve fibres have to travel forward. And they travel forward fairly low down near the base of the skull. So they have to pass over the base of the skull, partly made up of the occipital bone, and then as it moves forward, made up of the temporal bone on the floor of the skull, and then forward over the floor of the sphenoid bone. So we have these two oculomotor nerves going forward near the base of the skull. This means that the mass of the brain is on top of these two nerves, the right and the left oculomotor nerve. And these nerves function perfectly when there is a normal intracranial pressure. So the intracranial pressure is the pressure within the cranial cavity. And the normal intracranial pressure is about 5 to 15 millimetres of mercury, normally within 5 to 10 millimetres of mercury. So the oculomotor nerves will function in this normal intracranial pressure. But what can happen if the intracranial pressure is increased? Now, a primary head injury describes the damage that occurs to neurological tissue at the time of trauma. But after this, secondary brain injury can develop. And one cause of secondary brain injury is what we call a space-occupying lesion. So, for example, a hematoma could develop on one side of the skull or the other. So if there's an injury, for example, to the temporal bone, underneath the temporal bones on the side of the skull is the middle meningeal artery. And if the sharp edges of a fracture in the temporal bones cut the middle meningeal artery, that can result in an extradural hematoma, generating a space-occupying lesion. Or there could be a venous bleed underneath the dura mater, causing a subdural hematoma. Or a hematoma could develop in the brain itself. There could be an intracranial hematoma. And contusion is also going to cause localised inflammatory changes and increases in pressure in the brain. But very often in head injury, this is going to be worse on one side than the other. So this means there could be a raised intracranial pressure which affects the right side of the brain more than the left side of the brain, or indeed the left side of the brain more than the right side of the brain. So let's imagine a situation where there's a subdural hematoma on the right side of the skull compressing the right side of the brain. That's going to push down the right side of the brain, but of course the oculomotor nerve lies underneath the right side of the brain. So the increased pressure on the right side of the brain will push down on the right oculomotor nerve, compressing it between the base of the brain and the floor of the skull. And this will essentially compress the oculomotor nerve, reducing its function. Now, the fibres that control the pupil tend to run on the outside of the nerve. So this is often affected first. It's a bit like if your arm was on a chair and someone came and sat on your arm. Then your arm is being compressed between the person sitting on it and the hard chair underneath, and you're going to get pins and needles in your arm, and your arm is not going to work properly, and the circulation is going to be reduced. Well, it's exactly the same situation when the oculomotor nerve is compressed by increased intracranial pressure in the cerebrum above the nerve. We end up with reduced function of the nerve. And of course, the function of the oculomotor nerve is to give parasympathetic innervation to the pupil, meaning it would normally constrict the pupil. So what we find on the side of the lesion, where the oculomotor nerve is compressed, is that there will be a reduced ability of that eye to constrict the pupil. And initially the pupil can be sluggish. When you shine a light in it, it might still constrict, but more slowly compared to the other pupil, which is controlled by the opposite, in this case the left oculomotor nerve, which is not being compressed. So we're always comparing the two. And this is giving us information about the intracranial pressure, which could be caused by a one-sided lesion in the brain. And eventually, as the pressure increases, the oculomotor nerve on the affected side won't work at all, and the pupil can become fixed and dilated. Now the pupils are supposed to be equal and reactive to light. So pupils equal and reactive to light is a useful clinical finding. And unfortunately, this is often abbreviated to one of these appalling acronyms we have in healthcare, PEARL. So if someone says pupils PEARL, that means pupils are equal and reactive to light, which of course is normal. But damage or embarrassment of the third nerve, as we've said, can reduce the ability of the pupil to constrict, causing sluggishness and eventually palsy, which is a paralysis of the pupil. So it's the lack of the parasympathetic supply because of the reduced ability of the oculomotor nerve to innervate that parasympathetic supply, which gives rise to the dilation. And in fact, if you reduce or take away all nerve supply to the iris, we get dilation as well. So for example, in a cardiac arrest situation, we can get dilated pupils. And if you look at someone who's recently died, the pupils will be dilated and of course not responsive to light. Now the eye which has the reduced papillary reflex, the reduced pupil reflex, that the pupil will not constrict normally, is on the same side as the compressed oculomotor nerve. It's on the same side. So if it's the right pupil which is not constricting when you shine a light into it, the lesion, the raised intracranial pressure, is worst on the right-hand side. It's on the same side. In other words, the raised intracranial pressure, the compression of the oculomotor nerve, and the fixed and dilated pupil is ipsilateral. Ipsilateral means it's on the same side. The converse of this would be contralateral, meaning the opposite side, or bilateral, which would be both sides. But the poorly reacting or non-reacting pupil and the lesion and the compression of the oculomotor nerve are ipsilateral. It's the same side. And this observation is useful at all times, of course. It's an integral part of a head injury assessment, especially valuable if the patient's unconscious or sedated or intubated. Just a couple of provisos, though, to mention about the importance of this test. It can be an isolated finding in some cases of mild head trauma. So traditionally we've always taught that this is related to severe head trauma, but this isn't always true because it can be an isolated finding and sometimes in milder head trauma. So it's always got to be taken in the context of the person's overall score, whether there's lateralizing signs, what the Glasgow Coma scale is, and the context of the whole person. And again, when we're thinking about the pupillary reaction, we've always got to think about the context of the person in terms of medical history. Is there drug overdose? Is there pre-existing blindness or pre-existing nerve palsy, as can sometimes occur? Or indeed, is there local eye injury which may affect it? So there we are, the oculomotor nerve, very useful nerve to understand in healthcare, especially when assessing head injuries and pupillary reflexes.